Yeah, so the question is what's the role of raised cholesterol? So this is something now that has split the audience. So one of the largest studies was done through Salpêtrière, so from Charcot's group now. They did hundreds of thousands of patients, and they found that patients who had higher cholesterol did better. So their advice was to treat them all on high-fat diets, foie gras, enjoy it, and have as much as you can. Then the study was taken on by Leonard van den Berg and his colleagues in Holland, and they did not find that association. So they said they're getting all of these French patients coming up to Holland, and their first advice is get off the high-fat diet. So I think at this stage, it's an open question. I think that from the clinical perspective, I would say to patients, if they are on cholesterol-lowering agents, my tendency is to say to come off those medications. It depends on, obviously, that's not a carte blanche. Like if someone has, very unstable coronary artery disease, then I would not say come off your cholesterol-lowering medications. But I think the advice is cholesterol's in the region slightly elevated, 5 to say 7. I don't think they need to be treated by cholesterol-lowering medications. The other thing is cholesterol-lowering medications do have side effects. They cause muscle pain, etc. So I think from a symptomatic perspective, I would come off them. But that is not evidence-based medicine. It's more, at this stage, a recommendation.
Is there any evidence that it's attacking any particular ethnic or Anglo-Saxon groups? I know you mentioned the people from Finland. Is there any research on that, and why is it?
Yep. So some mutations do seem to be. So it's a mixed answer again. So that C9orf mutation is in the Vikings and Viking successors. However, the Vikings never actually made it to Asia, so that's part of it. So C9orf is virtually unknown in China, Japan, Asian countries. There are the occasional individuals who have it. I think we just saw a very large population-based screen from China, and they showed, I think, 1 or 2 individuals had C9orf. So Vikings didn't get there. So there does seem to be a difference. What we're trying to do now, and this is a study that has been driven by Leonard van den Berg, is we're trying from Holland. He and his colleagues have set up what's called Project Mine in Me. And what we want to do is get 15,000 patients, blood samples with sporadic motor neurone disease, and to study that, do their full genetic sequencing. And so Australia has put in to do that. That's with Ian Blair and myself and all of our colleagues. And we've been supported by the Motor Neurone Disease Association to do sequencing on 100 individuals. But by doing, say, this is like a 15,000 sort of individual basis, we will see much better the genes that underlie motor neurone disease, but also on the other side, genes that might be protective. So we have individuals who have the same mutation, like let's say a SOD1 mutation. Some of the family members begin with bulbar onset, some of them begin with leg onset, some of them begin with hand onset. The other thing is, with that same mutation, some of those individuals die from the disease in 6 months. Others, I saw a patient who I diagnosed in 2004, and she came back about a month ago, SOD1 motor neurone disease still alive, so she was able to come up from Wollongong. So I think that there are also protective factors, and we're going to get a much better understanding of that in the next 5 to 10 years.
Question over this side.
Is the same mechanism involved no matter which type of cause, like the blue-green algae theory that's going around at the moment, with the people from Guam who had 100 times the incidence or something like that, and there's some evidence in Australia even about groups of people who've been exposed to blue-green algae. Does it all come down to hyperexcitation? Have we nailed that, or is it likely to be some other reason?
Well, that's a good question. It's a controversial topic. So it does seem that all of motor neurone disease does seem to be linked to a hyperexcitability. So I think we could say that. In terms of the Guam, so that was Lydico-Bodig, and that was related to bats that ate a cycad nut, and that caused a toxicity that then led to a massive, so they used to eat the bat bat wings. It's a massive increase in motor neurone disease. Once people worked out that association and public health messages came out, that's disappeared, so it doesn't exist. But then people have thought that maybe somehow this blue algae is part of it. However, the blue algae parts, it's all through currents all around the world. So it's like saying water is a cause of motor neurone disease. I think it's up to people who espouse that theory to come up with some proper numbers, and so far they haven't. I mean, you can say that there's an increased incidence in Riverina. Well, again, I don't know how that's coming out because there hasn't been a proper epidemiological study in Australia to date that I'm aware of. So I think that these are all possibly parts that might be contributing. Now, another marker might be, for instance, variant CJD or mad cow disease. So in England, some individuals developed mad cow disease, but everyone was potentially exposed to that beef. Why is that the case? Well, it turned out that there was a genetic polymorphism, so part of a genetic structure, and if you had that particular change, you were then prone to develop variant CJD if you ate bad beef. But if you didn't have that polymorphism, you could eat as much bad beef as you want, but you were always protected. So there needed to be a genetic predisposition, but then an environmental approach. And I think that's what we're going to see in motor neurone disease. But we need, if it was a simple thing, it would have been worked out long ago. And I think that we really need large studies, as I'm saying, like the order of 15,000 individuals to try and get a better handle on this. But I don't think we can answer it as yet.
They're trialling something with GM6. Is that known to be helping at all?
So this is another tricky area. So this is a medication that has shown some positive results in a very early study, and most people would say that to really show it, you need to do a large study in a few countries. And the manufacturer of the medication has been reluctant to do it, but has sort of obviously asked, or has put the information out there. And so a lot of patients understandably want the medications. We've had a number of patients who've wanted the medication. It's very tricky. It costs a lot of money, but if they're up to it, they can get that medication. The other thing is someone does need to give it and monitor it. And we're sort of slightly hamstrung in an environment. To do a study like that, we need to put it through an ethics committee and get approval. So we are not able to just start patients on whatever. Patients themselves can do it, but I'm not able to fulfill that trial unless either the company sponsors that trial to be undertaken in Australia. And I know that the MND Association of Australia and the state associations are very keen for that sort of a study. I suppose the other thing to say is the only way that we can get studies to Australia is by having something like a national registry. So we have the Australian Motor Neurone Disease Registry, but companies are reluctant to come to Australia because it's a long way away, and we have a spread of population. So we've got large centres, Sydney, Brisbane, Melbourne, etc., but they haven't been coordinated in any way. And that's what we're trying to work towards. And that's one reason to be part of the registry. So then we can say that we have, 1,000 patients on the east coast of Australia that would be amenable or available for a clinical trial. So from our perspective, we're trying to facilitate it. And we've been part of the main clinical trials in the last few years with dexpramipexole, so we were part of that study. There's also been a anti-no-go study run by GSK, and we've managed to get that to Australia. So we're advocating to get the trial that you're mentioning to be undertaken in Australia, and until it's done in a large population or a population in a scientific way, I don't think we can say one way or another. The other thing is these are financial considerations, and obviously people who are running pharmaceutical companies want to make a profit. And if they can get people to buy the medications without any scientific background, then that's much easier.
Question over here. If you could repeat the question, please.
You mentioned that there's no medical records from conception, infancy and onwards. For children from a parent that has MND, is there any screening, say as young adults, that they could present themselves to?
So the question is about access to medical records, and particularly with individuals who have family mutations. So there's a colleague, Michelle Farah, who's a paediatric neurologist, and her interest is spinal muscular atrophy, which is a form of paediatric motor neurone disease. And they're now trying to get that as a notifiable screening investigations for all newborns born in Australia. So that's a work underway at the moment. But there isn't any other, there's no screening for the other forms of familial motor neurone disease. I suppose one key progress in that regard is we know now most if not all of the individuals from families with motor neurone disease. We've been able to identify them back from, and that's courtesy really of the work from Garth Nicholson in SOD1, but all the other mutations, and we know the various families. So that, and those individuals, if they know that they harbour a mutation, they can get it tested in themselves, and they get it tested in themselves before they consider having children themselves. And if they do have the mutation, we can now do pre-implantation genetic testing through IVF type technology, so we can ensure that their children will not have the disease. So we can actually stop the whole of familial motor neurone disease now. Obviously that's for future generations. So if you happen to be already alive, then obviously we can't change that. But I think this has been enough. That's part of the power of knowing whether you carry a genetic mutation or not. And this will also be part of the power of putting in these large 15,000 screening type of investigations in patients who have sporadic motor neurone disease.
I wanted to ask if the cognitive changes are correlated with age.
So the question is, are the cognitive changes correlated with age? So do you say, are the cognitive changes getting worse with age? Yeah.
Or showing up more?
Yeah, well, the cognitive changes are showing up independent of age. It's I suppose the type of disease that it is in each individual, and they're not the same. And we're not really sure whether patients with motor neurone disease who develop frontotemporal dementia are the same as patients with frontotemporal dementia who develop motor neurone disease. At this stage, they seem to be two ends of a spectrum. Are they the same? I'm not sure. But these cognitive tests are done relative to age-matched controls.
I was just wondering, have you found, like Ian was diagnosed with primary lateral sclerosis, the last 12 months or so symptoms have sped up, and then a fortnight ago we were in Canberra Hospital and I noticed the doctors were doing their exams, so they asked could they do that 7-minute test, and they had to come up with a diagnosis. And I noticed from their language that they were talking about a lot of lower neurone symptoms.
Yep.
And I mentioned it to the registrar and asked, said to him what, and he said, oh no, we all feel that he has amyotrophic. So do you find that it traverses, that the primary lateral sclerosis can become amyotrophic?
So the question is, I suppose, what is the basis of primary lateral sclerosis, and how does it fit in with amyotrophic lateral sclerosis? So the other thing that's become clear is that the two ends of the spectrum of motor neurone disease. So if you have pure upper motor neurone, it's primary lateral sclerosis. If you have pure lower motor neurone, it's primary muscular atrophy. And those two ends of the spectrum do much better than amyotrophic lateral sclerosis. So if you have the combination of upper and lower motor neurone abnormalities, you do not do as well. Now, primary lateral sclerosis, I would mention one thing. So at the moment, everyone is doing physician's exams. So people who want to specialise in medicine are doing their physician's exams. So they practice on patients who are available in hospitals, and they have a 7-minute examination. And most of these individuals are quite anxious, and they get their investigations and examination wrong. So I wouldn't be put off by the 7-minute. So that's just their anxiety. But
Sorry, the thing that they were really was the fasciculations in Ian's tongue.
Yeah. Yeah. So one debate is, does the condition primary lateral sclerosis actually exist? So a significant proportion, if not all, at some stage appear to develop amyotrophic lateral sclerosis. So, and that would be marked by fasciculations and muscle wasting. And that does seem to be the case. And it might be that patients have isolated or primary, just pure upper motor neuron features for potentially 10, 20, 30 years. But then there does seem to be a transformation, and people are wondering, was that transformation always possible, or is it something that's happened towards the end? And I'd say it's just part of what is amyotrophic lateral sclerosis, but at an extreme point. And there is a sort of everything has a population distribution. You have a common part in the middle, but you have extremes at either end. Another extreme clearly is Stephen Hawking. Like, what does he have? And I think he does have amyotrophic lateral sclerosis, but he is part of an extreme spectrum. The other part is that he has been managed on a ventilator for an extended period. And even now, people are wondering, is he starting to develop some cognitive abnormalities? Obviously, it's very hard to pick it up in someone of his high background, pre-morbid levels, but it does look like he is developing some cognitive change. So I think these are just the outliers of a major, but most people are in the middle somewhere.
Lou, did you still have a question?
I just wanted to ask, when you were talking about the familial genetic stuff, we've got a 4-year-old daughter. Where would, if she gets to that point where she wants to have children, where do we send her to get, like, I'm presuming not everyone knows what they're looking for when it comes to genetic testing for MND. So where would we send her to if she decides to go and get these checked out herself?
So the question is, what sort of a 4-year-old daughter of a patient with motor neuron disease? Can I just check, is it a form of familial motor neuron disease or sporadic?
We actually, based on what you're saying, there's probably good evidence for it to be familial, just that he's had cramps and fascicular, or cramps for in the chest area and the leg area for about 15 to 20 years. Was originally diagnosed with cramp fasciculation syndrome back in early last year, and just March this year, MND.
So, I mean, it sounds like it's not definite familial motor neuron disease. It sounds like you haven't got the mutation. In that situation, I'll take it on two sides. Let's say there's a family with a known familial motor neuron disease. We'll do both parts of it. So if it is a family with definite motor neuron disease and there's a 4-year-old daughter, I would say that there's no point bringing any of these things up until, you know, an adult type of age. So between the age of 16 to 20, and that really then depends on the individual themselves. Some people don't want to be tested, but that's up to them to make that decision. And if they ask me, should I be tested or not, I would say, yeah, I would be tested, because that gives you the power to stop this if it turns out. And if we know what the familial mutation is, yes, we can stop it. Then the next question is, okay, this is not familial motor neuron disease, this is sporadic motor neuron disease, what should we do? Well, I would do a screening test for the known genes, and we know that in about 5 to 6% of sporadic motor neuron disease in Australia, and this is a study done with Ian Blair, Garth Nicholson and myself, we showed that 5% have mutations of C9orf. So it's worthwhile screening any individual with sporadic disease. And if you find that mutation, then again, that gives an answer, both a diagnostic answer, but it also gives that information back to the family. If there was no known mutation, at least again the blood sample is available and that is stored. So with other mutations that might come to light, like all of these mutations have only come to light over the last 20 years, if we discover more, then that blood test can be tested for future family members. But if we don't find a mutation in that individual, then there's nothing more that we could do. But where could it be tested? Well, one example is the Michelle Farah through Prince of Wales Hospital, David Mowat, the clinical geneticist. But most large, capital cities, Melbourne, Brisbane, Canberra, Perth, Adelaide, you would have access to see a geneticist and have a screen done.
I have upper and lower and onset bulbar, and when I was diagnosed, they told me that my motor strip and my motor tract had deep white matter. You haven't mentioned any of that in relation to it being part of MND, or is that the cognitive side of things, or?
I think what you're saying, so the question is, combination of upper and lower motor neuron abnormalities with deep white matter change. Well, I think that's what I was showing on the MRI scan. In some individuals, when you do an MRI scan, you see deep white matter change abnormalities corresponding to the corticospinal tract, and that would be used as virtually diagnostic or confirmatory that that is the condition. So that is the involvement of the corticospinal tract in motor neurone disease.
And so can that lead into cognitive?
Okay, so the question then is, does the involvement of the corticospinal tract suggest that there's going to be cognitive involvement? Well, the corticospinal tract is the pathway that controls all of our voluntary movements, and it's a pure motor pathway. So that doesn't give us any indication whether there's cognitive or not. How would we know whether there's cognitive or not? Well, that would be firstly, obviously, a discussion, and we could do testing, so formal cognitive testing. The next thing is, what did the rest of the MRI scan show? Was there any atrophy or shrinkage involving the frontal regions or the frontotemporal regions that may suggest that? So you could take that up with your treating neurologist or team.
Question up the back.
Is the incidence of dementia increasing with MND patients? Frontotemporal? And one other question, is there any combination of Asperger's and frontotemporal lobe dementia?
So the question is cognitive involvement increasing in motor neurone disease? Well, I think this is one issue that we've got better at understanding it and diagnosing it. So awareness of cognitive involvement has recently become apparent. And I can say again, 5 or 7 years ago at international conferences, this was debated. Now I think, particularly with the understanding of this genetic mutation, everyone I think accepts that it is part of the condition. So there has been actually an increase in incidence of cognitive involvement, but that's not really a true incidence because more that people are actually testing it and now understanding it. But then on the other side, if we are seeing a marked increase, potentially a trebling of the condition from 1970s to now, then yes, you're going to get more increase in cognitive involvement. In terms of, are there other associations like Asperger's syndrome? Well, for some reason, the C9orf mutation is associated with psychiatric presentations. So irrespective of any of this discussion now, people who look after schizophrenic patients are testing for C9orf. People who look after bipolar disorder are testing for C9orf. So there's a higher incidence of C9orf mutations in mental illness. And then the question is, do some of those individuals go on and develop motor neurone disease? But it looks like this is now a very large spectrum, and there are different ways to come into it, be it through motor neurone disease, be it through mood-related disorders, be it through frontotemporal dementia. And we're now getting a much better understanding of this. And the other thing is, when we look at patients with motor neurone disease, we're now taking very extensive and extended family history. So before we'd say, look, anyone else in the family have motor neurone disease? They'd say no, and that'd be the end of it. But now, has anyone else in the family got a history of Parkinson's disease? Oh yeah, my uncle had Parkinson's disease. My niece has multiple sclerosis. A second cousin has bipolar disorder. And in large population studies, it's shown that this is more than by chance alone. And I think that we'll see that there are certain families, clusters of cancers occur in families. And I think clusters of neurodegenerative and neurological disease occur in families. So I think that's going to be the message. It doesn't generally occur in isolation.
Okay, well, I think that's all we've got time. But are we out of time?
Yeah,
Or?
What's the percentage of
Last question.
misdiagnosis of MND with something like multifocal motor neuropathy? Is there a big sort of misdiagnosis? Initially people being diagnosed with MND, then
Yep.
MMN?
So across the whole area, as I said, it'll be about a 6 to 7% getting it wrong. And if they do get it wrong, it's usually two conditions together. So patients who might have a stroke and diabetes and have a diabetic neuropathy, so they have upper and lower motor neurone combined. Another key one is multiple sclerosis. But then I think the key from MND is multifocal motor neuropathy with conduction block. And that condition is very hard because patients have wasting fasciculations, and they often have brisk reflexes. So yes, there is a large overlap, but it's confirmed through the neurophysiological investigation. So if you don't see focal conduction block, so in other words, a block of the signal in the nerve from the wrist to the elbow, then it's not going to be multifocal motor neuropathy. So what I would say is I wouldn't want everyone who has motor neuron disease to be treated with multifocal motor neuropathy. And why is that? Well, the treatment is intravenous immunoglobulin, which is a high protein load, and we've already had a number of individuals who've developed DVTs, so deep venous thrombosis and pulmonary embolus, courtesy of the IVIG, intravenous immunoglobulin treatment. So I think it's much better trying to clarify the diagnosis. And yes, multifocal motor neuropathy is one of the differentials for motor neuron disease and is commonly misdiagnosed.
So what percentage was that, 6% you mentioned?
Well, that's slightly different. If we went through everyone who has multifocal motor, if we went through everyone who had multifocal motor neuropathy and said, were you misdiagnosed with motor neuron disease, it'd be probably a much higher misdiagnosis rate because the conditions do look alike.